Good morning, everybody.
Right.
For listening remotely. See you all here on a Friday. So many orange shirts, which is great. And I think we have some visitors from the Center for Aging. Welcome here. The Center for Aging is a co-sponsor of Silvia's appointment. I'll just say a few words about Silvia, and then we'll get rolling. So, Dr. Stringhini first studied at the University di Pavia in Italy, then went on to complete her master's degree in global health at Trinity College in Ireland. She also obtained a PhD in Epi and public health. It was a joint degree from University of Paris and UCL, which is University College of London. So she has a unique background. Her degrees are from all over the world, and these might be from the developed countries, but she's also had a lot of experience in global health. She's an associate professor here, and she joined us just this fall, and between 2018 and 2023, she served as the head of the Unit of Population. She served at the, I don't know the name of the unit, but in the university. Huh?
It's Unit of Population Epidemiology.
Yeah, Population and Epi. And she was also the director of a research group over there at the University of Geneva. She's the PI or co-PI on several population-based studies, including Bus Santé study and the SEROCOV-KIDS study and the SKIPOGH studies. They're big names, and she's been on several Swiss studies. She's been on the scientific, so she's collaborated with a lot of people. I recently suggested she applied for it, and it involves France and Canada, but very party to the France. We have collaborated with her. Yes, she was in charge of big studies, and so she had too many collaborators there. Anyway, we're looking forward to your talk, and we really appreciate you being here and being part of the faculty, and we're really excited to have you.
Thank you so much, Aslam, and thank you everybody for being here and also for welcoming me as a staff, as a faculty in the SPPH and UPT. I'm very excited about what I can do. As you will see in this presentation, I will talk a bit about the epidemiological side of the domain, which is the biological incorporation of social inequalities. And I just wanted to say a little bit that in the past few years, we, as a head of Unit of Population Epidemiology, I really almost stopped my basic research to dedicate the unit to COVID studies. So some things are a little bit earlier in the past, and then we continued, but the majority of the activity was COVID related. So I'm not going to present it here because the idea also is that now I will go back to the research that I had been doing just before COVID hit. And in the position I was, I had to do all the time service. And then also another thing I wanted to say is that a lot of what I'm going to present is my own studies, but of course it's not because everything is just this is my talk. I prioritize what we did, and this discipline is enormous with a lot of people here that have been contributed largely to it. So I will discuss a little bit about social inequalities in health. I know several people work on social mental health in UPT, but I just wanted to give an overview and also this perspective that we have that is really global. And then I present the theoretical framework that we have been working on in my lab on understanding these inequalities. And then I'll discuss a little bit about the evidence on the biological consequences of social inequalities. And finally, we'll talk a bit about the challenges of this field, and also I hope about perspectives. And I hope that we'll be able to discuss also, because I don't know anybody, and it will be great to also to have your suggestions on who I shall approach and which data I can use, and so on. So we all know there are huge inequalities between countries, and this is just an example. You can understand of the screen. So, for example, here it was life expectancy at birth, and it ranged. This was, I think, 2010. It ranged between 50 years in Sierra Leone and 83 years in Switzerland. However, we also know that inequalities of the same magnitude exist within countries, and this is a study that was conducted in 2016 in the US, and they show that life expectancy at birth ranged between 87 years in the top percentile of income and 72 years in the bottom percentile of income. So these inequalities within countries are as huge as they are within countries. And on the other hand, socioeconomic factors are rarely recognized as major risk factors for diseases. And this is a study we did in 2017. We used data from about 1.7 million participants in 7 countries, and we calculated the population attributable risk to select the risk factors. And these were the factors that were identified as major targets by all global public health strategies. And we show that low socioeconomic was responsible for about 20% of the premature mortality burden, of a figure that was similar to that of major other risk factors such as smoking or physical inactivity, which were then the target of major policies at the global level. We also have been working in my lab on the impact of socioeconomic conditions on morbidity. Socioeconomic factors have an impact basically on almost all diseases we can imagine. The socioeconomic gradient is sometimes reversed, as we all know, but in general, it favors people with high socioeconomic conditions. And this is a study where, again, we use data from 8 European countries and show that individuals with a low versus high occupational position had about 50% increased risk of coronary heart disease, and then a little bit lower for stroke. A lot of studies have concentrated on the impact of socioeconomic conditions on hard outcomes such as mortality or incidence of diseases, but we all know that they also have, before they translate into diseases, the socioeconomic conditions have impact on functioning. So in this Lifecourse consortium, we started looking at the impact of socioeconomic conditions on measures of functioning and aging. And in this study, we looked at the association between socioeconomic conditions and the trajectories of working speed. This is the English longitudinal study of aging. I think it has parallel with the Canadian longitudinal study of aging. It was established much earlier, so the data spans over decades, which is what we need to have for this kind of studies. And here in the country, people with high socioeconomic conditions, middle socioeconomic conditions, and less advantaged socioeconomic conditions. And we show that individuals with a high socioeconomic conditions at the age of 80 have the same physical functioning as measured by walking speed as those with the low socioeconomic conditions that were 10 years younger. On the same type of studies, we and again using the Lifecourse consortium data, this time on 50,000 participants who had data on lung function, we calculated a measure which is called years of functioning lost. And that is a summary measure calculating based on this particular indicator that in this case is lung function, how much you lose in terms of functioning by having a particular risk factor. And in this case, the risk factor was low socioeconomic conditions. And we show that, for example, among men, versus economic conditions were related to corresponding to about 5 years of functioning lost as measured by lung function for men and about 4 years for women. A lot of research that we did was also meant to understand which were the mechanisms linking socioeconomic conditions to adverse health outcomes. And the idea is really that the socioeconomic conditions can affect health outcomes partially directly, but also via exposures to many other mechanisms that are generally grouped into environmental exposures, lifestyle factors or behavioral exposures, all things related to psychosocial factors, stress, social support, and others, and then the access and use of the healthcare system. And so a lot of research has been conducted in trying to disentangle these different pathways and how much they contributed to social differences in various health outcomes. And then we started working also on the biological incorporation, knowing that all of these factors, on one hand, socioeconomic conditions, but also all the factors that are related to it, they have to have biological consequences before translating into health problems or issues. But then there is another layer that we had to add to that framework. Indeed, as we all know, all of these factors and socioeconomic conditions accumulate across the life course. So the idea, this is just an example of a study where it's a very old one, where we looked at the impact of life course socioeconomic conditions on type 2 diabetes incidence. This is the British Vital 2 study that probably many of you working in AP know. It's a very nice cohort dating back in the 80s, so it has been followed up for a long time. And we generally use two indicators of life socioeconomic conditions on these cohorts that are including middle-aged participants. One is for cumulative life socioeconomic conditions, and we measure how many times across the life course someone was in a low or a disadvantaged socioeconomic conditions, and then we sum and we do a score. And then the other one is a social mobility measure, where we just take either 2 or 3 points in time and we calculate the trajectories. Either someone was in a stable high socioeconomic condition, a stable low, or had an upward or downward social mobility. What we showed here is that something we knew already, but that adverse socioeconomic conditions all across the life course were associated to an increased type 2 diabetes incidence over the years, and that the association was graded. So we observe a dose response association, and we generally observe it with socioeconomic conditions as a risk factor. But this is just to say that to the framework for the understanding of socioeconomic conditions and their link to health, we had to add a life course perspective. So the idea is that health and functioning, they are influenced by all of these factors from conception. And this is adapted from a famous model that is used for life course research, the Strachan model, where health is conceptualized in 2 periods: a period of build-up of health incapacity that is followed then from middle age to a period of decline. And all of these factors influence at the same time the maximum level of health attained and the rate of decline. And of course, for different people, all of these factors, including genetic factors, contribute to different trajectories of health and aging. And then this creates these differences between individuals and groups. So this research is meant to try to disentangle not only the mechanisms in a point in time, but trying to understand how these mechanisms and the pathways interconnect with a sort of life course perspective in mind. what we started doing to try to summarize the biological incorporation of social inequalities was to look at these biological markers that could explain differences in ages. And this is just a table that we took from a publication of Geneva in 2012, where they actually show that in all the systems we could find association between socioeconomic conditions and biomarkers. But generally, the research in this domain has focused on some systems, the HPA axis, the inflammatory and immune system, the genome or gene regulation part, and then also the brain structure and function. What we started doing in my group was to look at the impact of Lifecourse socioeconomic conditions on inflammation. And here in this study, this graph shows you again the same two measures that we. So this is a mistake. Okay, sorry. So it's again the social mobility trajectory, and it shows the concentration of two inflammatory markers. These are CRP and interleukin-6, depending on the Lifecourse socioeconomic trajectory, showing that those, for example, that had an increase at the higher level were most who experienced adverse socioeconomic conditions both in early life and adult life, and again a related association for this variable. And in this study, we also looked at the contribution of this differences in inflammation to the socioeconomic gradient in diabetes, and we showed that around 15% of the gradient could be explained by these differences in inflammation. And then again on this, trying to understand more deeply the link between socioeconomic factor, inflammation, and diseases, we started looking at the role of gene regulation. And the idea behind is that these Lifecourse socioeconomic conditions have an impact on inflammation-related diseases, such as diabetes, that we were working on via inflammation. Two types of risk factors that are interconnected, the lifestyles, but also gene regulation. And there has been a lot of research at the time looking at the impact of socioeconomic conditions on gene regulation. And one of the first studies that had been published was this one on macaques that I still consider a very, very, very interesting study. Dominant rank in macaque can be considered as a proxy of social status for human. Of course, there are a lot of differences, but the idea here was that they actually looked at the expression levels of several pro-inflammatory genes in macaques, and there was a patterning by dominant rank. This is the lowest dominant rank, and these macaques had a higher expression of these genes the lower the rank. But what was very particular in this experiment is that they actually first they built a model where they could predict the rank just by looking at the gene expression. Then another very important feature that really conditioned the research afterwards was that they were able to show that a change in the rank of these macaques, changing then the position in the cages, the methylation levels of the genes and their expression changed. So that opened the possibility to whether these even epigenetic modifications related to socioeconomic condition could be reversible. And in our group, we started with a study using an Italian cohort that had data on socioeconomic conditions across the life course and DNA methylation. And we used actually the same genes that in a few studies, that one and some others, had been associated with the social related regulation. And we were able to show also in humans that a lower socioeconomic conditions across the life course was associated with decreased methylation of these pro-inflammatory genes, suggesting a higher expression. We do have data on expression in this cohort. But then going back again to this framework where we try to show social differences we try to show the impact of the life course on socioeconomic conditions and biological incorporation. people started developing the idea that we needed to look at a single, like a more composite marker of biological age. Of course, all the literature on biological age dates back further than when social epidemiology started taking an interest in it. It's a very promising domain where, of course, you have to find this indicator that can be a proxy of mortality, morbidity, or pharmacological intervention and others. But the idea is really that people at the same chronological age may have different biological age. And then there have been a lot of measures developed to try to capture this biological age. And we have been working on a lot of those, but in general, one of the first that social epidemiologists have been looking at was the allostatic load measure. That is a sort of composite measure of dysregulation in several systems. And then others that have been developed and more recently very much studied is the epigenetic age based on DNA methylation markers. And then there are many others, either used at a molecular or cellular level. And then there are others that are also known such as frailty. Here is just an example of a study we did looking at socioeconomic trajectories and several measures of epigenetic age. So even though it was supposed to be a composite measure, now there are maybe 5 or 6 of epigenetic age indicators, because people try to understand which is the one that is most related to health outcomes or is more predictable of future health. So even though it was supposed to be composite, now we still have a lot of those. But these are just two of the two composite. And what we showed here using data from actually a Swiss cohort, where we had a lot of indicators on socioeconomic conditions across the life course, because we were lucky to be able to add in the second follow-up of the study. And we also had data on DNA methylation, and we showed again a small association between socioeconomic conditions across the life course and this epigenetic age, where people with disadvantaged condition generally are epigenetically older, as measured by this indicator. And then in another study where we used another Swiss cohort, which was in this case very much phenotypes in terms of other blood-based biomarkers, we looked at again the social mobility variable and showed and used this indicator that is another Belsky phase of aging indicator, and we showed here again that having a low socioeconomic condition was associated to being older with this measure. So then, again, how do we explain social inequalities in health with keeping in mind this biological integration and the Lifecourse framework? We did originally some work on using, example, trying to understand the contribution of health behaviors to social inequalities in health. And in this study, which was again from the Lifecourse consortium, we reviewed more than 100 studies and showed that about 1/4 of the socioeconomic gradient in either mortality or morbidity is generally explained by the social patterning of lifestyles. And then in another study, which we also showed that a part of it is linked to sleep, but then as you can imagine, they are all interconnected. We also have been looking at the impact of social support and psychosocial factors. This is another old study that we wanted to cover, and then showed about 30% of the gradient in mortality could be explained by differences in social support. But again, there is also an interconnection between psychosocial variables and lifestyle factors. And then all of these studies were based on a method that is the difference method. They call it in epidemiology, you just do a model and then you add a factor and you look at how much the association of your exposure with your outcome changes when you enter the mediating factor, but it's not the most clean way to assess mediation. So what we started looking at was to try to use more advanced techniques such as counterfactual mediation modeling to try and disentangle all of these pathways. And this is just an example that I'm not going to go into, but it was a paper where we actually also try to understand causally the interconnections between the different factors already of socioeconomic conditions across the life course. We know that socioeconomic conditions in early life are related to heightened inflammation in adulthood, but is it via socioeconomic indicators in adulthood, or is it via educational attainment that then conditions occupation, that then conditions lifestyles, and then again the heightened inflammation, or is it directly through financial hardship in adult life? So this one was really more of a conceptual paper where we try to enter these variables in a counterfactual mediation framework and try to understand what was happening. And the idea would be to also apply these models in the understanding of this pathway that I presented earlier. So I'm already in the conclusions. There are a lot of challenges in this type of research, and the first I would mention is that there are really a very small amount of studies with good biomarkers across the life course and with very good indicators of socioeconomic conditions. This is really very hard to find. And then, of course, the major barrier of all life course research is that it is very difficult to trace exposures across the life course. And there is really a very limited number of both cohorts that have data on biomarkers and that where participants are old enough that we can actually look at the impact on morbidity from middle age. Then, as you have seen, probably the effect of socioeconomic conditions on these markers of biological age or epigenetic is quite small. So the clinical significance or the significance or the public health significance of that is uncertain. We don't know whether it's just because we measure one single thing at a time, but it's still uncertain at this point what we can do with it. So the impact of this research on health policies or the clinical application is still not clear. Then the studies are generally using data from single cohorts or countries. We had a Horizon 2020 consortium, that LifePath, that really tried to look at a lot of cohorts at the same time. And it is really an incredible effort. It takes a year just to harmonize the data. Not always you have the data you need in all the cohorts, and then you're limited to assessing just A and B and not the whole set of things that you could have been doing in a single cohort. So the temptation is always, I'll just do it here. It's so much simpler. But on the other hand, it's so much less generalizable that I think it's, I don't know, we have to understand whether it's worth the effort. And then, as you can see, we have been spanning from gene regulation to social factors to health behaviors to diabetes. So I'm clearly not an expert of probably none of those. So this research really needs a lot of multidisciplinarity. Every time we had to work with experts. I know for sleep, they were sleep experts. I was working with diabetes experts, and the idea is always that you have to find the expert on one domain to be, if you want to solve that the huge puzzle of understanding social inequalities in health. And then which are the perspective and what I could be doing here. Again, the multi-cohort comparison, it's frightening, but I have a lot of experience in cohorts in Europe, and I was thinking maybe it's time where we can combine data across the continents. This is just an example of how differences in health vary across country. The self-reported health and the proportion of the population reporting poor health, and in this report we vary between 60% of the disadvantaged Latvian to 10% of the advantaged Irish. So also the gradient extremely varies between countries, and the mechanisms to explain inequalities vary between countries. Then another possible idea is to study the role of factors that have already been studied in relation to socioeconomic factors and the social gradient in health. This is just an example of the impact of socioeconomic conditions on living conditions. It's a survey where they actually ask people the number of problems in their home, from damp to cold to other type of living condition problems, and then it's the proportion of people reporting low self-rated health, and as you can see, of course, having more problems was related to a lower self-rated health, but it was depending on the level of income of the residents. And so the environmental factors, not only living conditions, but also exposure to pollution or toxics in food or in soil, or I don't know, maybe fires, they are related to potentially socioeconomic factors, and they can be an important mediator of social differences in health. It's still not sure the direction. I found a study actually in Vancouver of many years ago where they didn't see an association between socioeconomic conditions and this air pollution. And then it's quite common to find it somewhere, not find it, depending on where people live, actually, I think, in the different cities. But there is also a lot that I've seen on exposure, for example, via food or other things. And in general, there is a lot on environmental research, but a little bit only when socioeconomic conditions are measured at the individual level. A lot of these are using socioeconomic conditions at the area level, and of course, you have a bit of a problem when you're also using your outcome of environmental exposures at the area level. And then I haven't found any study where they actually take mediation analysis to look at the contribution of these environmental factors to social differences in health. Then another idea and thing I would like to focus on is the socioeconomic trajectories from and the aging trajectories from early life. There are a lot of people in SPPH working on social differences in early life, and we know that from early life, children from disadvantaged conditions are more likely to have low birth weight, shorter stature, they are more frequently hospitalized, they have slower cognitive development in early life. At the biological level, there have been plenty of studies showing associations, for example, with inflammatory markers. And then there are some studies showing that premature babies have accelerated senescence of cord blood endothelium progenitor cells. And then we know the socioeconomic conditions are associated with preterm birth. So the idea would be to start looking and finding data where I could be looking at the first period of life and understanding whether the biological trajectories, the aging trajectories start diverge from early in life, and most importantly, by which mechanisms. And then finally, another part of research that I would like to, I was thinking it would be interesting to do is to look at resilience factors and try to understand if these trajectories are determinist or which are the factors via which we can actually modify this potential divergence of aging trajectories. These are just a couple of studies showing that lifestyle factors can buffer a little bit the effect of adverse economic conditions in early life on health in adulthood. And then a couple of studies, one of which was Michael as a co-author, looking at factors that can potentially affect and maybe moderate the effect of socioeconomic conditions. So to conclude, we have seen and we know that socioeconomic conditions are major determinants of health and mobility, and they impact aging trajectories. Several set of factors are implicated in the generation of these inequalities, that both directly and indirectly these social disadvantages biologically incorporated, and this happens from early in life. That the research into whether the biological implication related to social exposure is modifiable and how it is at its early stages. And then there are a lot of limits and problems in this research. There is little good data. There are intrinsic limitations in capturing lifetime exposures. There is a lack of comparative studies, and then there are some methodological difficulties, and then there are difficulties, of course, in having to be so multidisciplinary. And then again, I will not have time to talk about the policy implications of this research, but probably to be able to be at the stage where we can give policy recommendations, we would have to have another set of tools that are even more complicated than the ones that I have described. So I wanted to thank you, and then also to say, please reach out to anyone who has some sort of research that is potentially linkable to the one that I have been doing, because I have to rebuild my network here. So I would be very happy to see what we can do together. And then, of course, I didn't do any of these on my own. I even told Aslam that I don't even have a software now that I can use for statistical analysis, because I've been working with so many people, and I want to thank them all, even if they're not here.
That was a great talk. A lot of it packed into a very short time. You've given us lots to talk to you about, and you've given us some good time. And so that's great. So we have a couple of questions. Put your hand up. I have the Zoom screen up, and then there are also questions. And so, to be fair, let's alternate questions between the remote listeners and the listeners here. Okay, so I registered Boris and Eva. So let's start with David. Go ahead, David. Can you hear me clearly?
Yes, I can. Yes, I can. Silvia, David Patrick from BCCDC. We spoke by phone a few times, and it's lovely to see you here. I think our late colleague Clyde Hertzman would be delighted to see you bring your program of research in this regard. When we talked, I let you know I do infectious disease epidemiology. So to a man with a hammer, everything looks a little bit like a nail. And I'm wondering what your thoughts are on considering mediating factors between environment and those biological consequences, as we have seen the host microbiota play a pretty big role. Lots of evidence amounting now in terms of it being the mediating factor that communicates with the developing immune system to protect against atopic disease over time. And then we've got people looking at neurodegenerative conditions in the same light. So I'm wondering methodologically, if you've got any insights into how we can pursue that mediating role of those trillions of bacteria that live in us and produce metabolites and interact with
Yeah,
easy question.
Easy. Exactly. Thank you very much. So I think we had the same problem when we tried to look at the impact of inflammation, of DNA methylation in mediating social differences in inflammation, where generally in the mediation studies we had, I don't know, 2 factors to assess the mediation of, and then with DNA methylation we were like with 20,000 different factors, and methodologically it's extremely complicated. I think for now, at least the counterfactual mediation framework tools, they are still not developed enough to be able to put all of these mediators and the various interconnections between the different indicators that you have and time at the same time. What they can do though is that they can help in the model, so it's still data driven. They can help understanding what's coming first. If you have an exposure of some mediators and the outcome, and you're not quite sure, especially with this, I imagine the metabolomic data as it is with the the expression or the methylation data, you're not quite sure what's coming first. They can help a little bit with that. But yes, it's really complicated generally to be able to do that. But the microbiome, on the other hand, is something we hadn't been looking at as social epidemiologists, but it's also another potentially very interesting pathway, as you can imagine, via either environmental exposures, but also food or all the infections from early life. And it's another putative mechanisms where from early in life, you are exposed to a different set of things that in the end permanently stay there. So as another close to potential parallel to epigenetics.
Yeah, thank you.
So I don't have an answer to to solve this problem.
No worries. Thanks. Well, we'll make an effort to get you out to CDC with our population health and data people really soon, just to compare notes.
Thank you.
Thank you, David. Boris is next.
Silvia, thank you very much. My name is Boris Sobolov, and I'm interested in everything about causal analysis. So your talk is so fascinating, so inspiring. I have only one small question. How can I be part of your research?
Thanking you. I really, it's true that is, to be very fair, like I've been working with this postdoc that is the one who created the pathways of co-infection mediation, and we have been working together, but I'm not the one who's doing the stat part. So that's also something that I really need to find here, someone who can work with me in really trying to actually do it, because it's interesting, but I'm not the stat person. I'm not the epidemiologist, so I'm very happy to
Put me in your book.
I just wanted to
Okay. So we go back to the. There was somebody with their hand up and they put it down on the screen. No, it came third. There was somebody else who had their name up. Was it somebody on the screen that put their hand down? They're being polite, but maybe they put it in the chat. But okay, since you've gone back, I'll let Ken go.
Oh, hi. I'm Ken. In my younger days, I was trained as a medical microbiologist and an immunologist. But I want to touch on the real life situation. You might talk about the problems of poverty affecting the biological outcome. But if you look at a real life example of SARS and COVID, the rich are just affected by the same. The rich doesn't have the immune system being, improved to such a extent much better than the poor. So from that real life perspective, I wonder, economic situations really affect the biological genetics outcome of a person's health.
Well, it's true that at least in the studies that we had in Geneva, and then I've also been working at European data on, there wasn't a clear association between socioeconomic factors and, for example, the antibodies against SARS-CoV-2. Although what we had seen at the beginning was, of course, because of how life is, that the infections were much higher among the disadvantaged, especially those that were working in places where they were more exposed. Then in our own data, it was mixed, because you had a mixture of high CS people, like all the doctors and those working in retail and other places, grocery stores where they had to be open. So it was a little bit unclear. On the other hand, so the biological incorporation is a little bit direct, meaning that there is some evidence that social factors, or maybe the relative position you have in society, can be actually in some ways biologically incorporated. But then most of it is through exposures, and I don't think we can object that people with a low socioeconomic status are higher smokers. They have low physical activity. They have lower access to care. So via all of these other factors, then you get to this biological incorporation. So the thing is, and then also since the observed differences in health, they are huge and they are being shown whenever you just try to look at it. I don't think there is a question of
Thank you.
I don't know.
Thank you. I think Eva was next.
Hi, Silvia. I'm Eva Oberle. I work, I'm a faculty with the Human Early Learning Partnership, and you've maybe heard a little bit about the data we collect on early childhood experiences, middle childhood, and early adolescence. And I'm curious because especially in the early adolescent years, we collect a lot of the data on childhood experiences that could potentially be assets and protective factors. So I'm curious if this is anything you've kind of thought about, thinking about these data as having, I mean, a lot of these are relationship-based assets or assets of how school environments are designed or school connectedness that could be protective factors for some of these outcomes. Maybe, you know, a lot of them also we try and relate to mental well-being throughout the lifespan, and some of the researchers are linking the data and building larger data sets. So I'm curious if this is something
I think
you've thought about.
Definitely be, because what we see, and at least for the we didn't talk about policies, but everything that is outside the agency of the individual, but it's like more of a structure of things like, improving school or improving the school outcomes of those disadvantaged kids, like with structural measures. That's the only way that actually in general you can get to reduce this gradient. And so whatever all these factors that are related to even the relationships and what happens via schools in early life, I think they're major factors. We haven't been looking into that because we don't have the data. We actually have established 3 years ago a cohort of children in Geneva, and we are working now on a school questionnaire and trying to see how we can capture exposures via education. But I'm sure there are a lot of things that can be part of this resilience pathway to trying to not be trapped into what happened in early life.
These are actionable
Exactly.
Factors. These are, because it's great to see the data. It's really sad to see the inequities. Changing socioeconomic status is not as easy as changing, making a change in a context where you can build assets and protective factors for children.
Absolutely. So everything that is like that, we have been working a lot on the behaviors, but of course they are not, they're probably easy than tell you, okay, become rich, but they're still something where, as we know, it's not that easy to say, okay, just you have to do more physical activity and then you'll be fine. While other things that can happen outside of the agency or time or will or resources of an individual, they are much more actionable. And there's something that actually we can recommend policymakers to do. So,
thank you.
Okay, we go back to the remote listeners. Good question from David.
Yeah, I just was thinking, Silvia,
David. Not you, David.
Okay, sorry, I've got a first mention.
Hi, I'm David Birnbaum. Among other things, I'm working with the National Health Experts, and they're revising their certification exam. They're looking to add more questions regarding education and literacy regarding public health impact. So I'd appreciate your thoughts as to whether education level and literacy level has a direct impact on health and adverse health, or whether once you've adjusted for things like low income in later life, unhealthy work environments, unhealthy health habits, the education and literacy impact disappears.
Yeah, from what we have seen, it doesn't disappear. So it's sort of cumulative. So what you really have is that it's like seems like a game. All the times that you can have a high socioeconomic status or high socioeconomic variable, it still contributes a bit to having better health. So the thing is, so it doesn't actually get cancelled by lower income later in life. It's just more that you still don't get all the health you could have if on top of having high education, you also had high income. So, and then the health literacy is another very important pathway that we have been thinking about and we didn't examine yet, because In the cohort studies, you generally don't have a lot of data on that, but it's supposed to be one of the ways through which education impacts health, as you probably know. That's why you're assessing it, I imagine. And so that's something that is also maybe easier and more actionable than education itself. And we were trying, just before I had to move to other type of activities, we were trying to see how we could add health literacy data into these population cohorts that we use. But to answer shortly to your question, I think it's still, even in the studies that used actually experimental data or like, I don't know, changes in policies to actually try to find the causal impact of education, they actually were able to show really that this association is probably causal between education and health, at least partially.
Thank you. Anybody from the room here?
Patrick is still waiting.
David Patrick is in the next sequence. He's remote. If nobody has a question, I could ask a question. Oh,
Short comment from me, just the paper that you cited, the Canadian environmental factors, when the lead author, Paul Villeneuve, is in the building today.
Oh,
So
okay.
we will, yes,
Well,
he's
that's great.
visiting, so we will make a point to try and connect the
Thanks
two.
a lot.
Yeah, yeah,
It would be
yeah. Oh. Yeah, that's
that was a
enough.
I have a quick question. And that is that, you know, when you first started and you showed the direct effect and the other indirect effect, and then you went on to show how the mediation. So in the first model, you didn't do mediation analysis. You just tried to estimate something which was incorporating all those factors. Right?
well, is when I started doing this type of research is now 15 years ago, maybe.
Yeah.
They called it mediation, but then in the end, it's just something that you just do with the model, and it's not causal mediation. It's not really trying
So
to
use some kind of control.
exactly. You control, and then you
correlate.
calculate the percent change in your association when you enter one factor. It's just.
Or with a factor analysis?
No, it was a simple, I think it was Cox regression models, and then you
It's like a sensitivity analysis.
yeah.
Okay.
And
So
then you-
just to finish of that question, how did those coefficients compare with the mediation analysis for the same factors?
Well, the problem that's why not many people do counterfactual mediation analysis is that sometimes you cannot have the same models. For example, I think they developed the package recently on using Cox regressions, but we had the longitudinal data. We had repeated mediators. So you have maybe in Y2 cohort, you had 30 years, maybe 10 times the mediators. And then you have varying exposure because socioeconomic status change. And then there's simply not a way to do it using the clean mediation.
Economists have a method, I'll tell you.
Yeah, I'm happy.
Two-stage least squares and.
Yeah, and then you have to also in this medical literature, you have to try and find also the relative inequalities, not just work on data and just because of the way this literature is. But I'm happy to. I know that it's a huge limitation. We did a bit. We ran the models maybe 1,000 times. We built confidence intervals around the percent mediated with bootstrap. So we tried to do everything fancy we could find to be just not a simple thing. But on the other hand, it's also limited in terms of methodology. But I'm happy to.
Okay, back to David.
Yeah. Silvia, I love that observation around maternal warmth and things moving on. But I was just wondering whether there was separate measurement of breastfeeding in that model. I want to believe it's the maternal warmth, but breast milk is wonderful stuff that has amazing physiological stuff.
Yeah, I didn't read through that. I just found it to try to find someone here that worked on that. But the breastfeeding, yes, is another I don't know, it's another factor, unfortunately, maybe that with a lot of things including guilt, but it's like, so it's just something that I didn't look, I mean, all the data that you have shown, maybe the most of it is where socioeconomic, all the exposures in early life, they have been captured in adult life. Meaning that you actually add questionnaires to these adults, asking them about exposures in early life. In some cohorts, you still have information about very precise indicators such as breastfeeding, but to be taken, with a grain of salt because they are reported by the participant for early life. So we didn't have much on that, and even other things that you could be using that are very important, like birth weight. Like premature birth, they are all a little bit confused by misclassification and memory bias and all of the things you can find in here. And but yes, I think it's another thing where another reason why I really want to at least have a bit of research that is using clean data from early life and potentially build around this, since I still have 25 years to work and wait what happens next.
Okay, I got a text from Sharmila to wrap it up, but there are questions here. Amy has a question. I'm sure it's microbiome related.
No, David took that one. He's still. So not my area, but I'm interested in. So when you were doing kind of meta-analysis across multiple cohorts, did you see the magnitude? And obviously, it depends on what you're measuring. But did you see the response to disadvantaged? Was it different? Like, could you point to society-wide or policy, country-wide policies that would change the magnitude of the consequences across different cohorts?
I don't know if I have it here. No, I don't have. So yes, in general, it's the social gradient, or let's say mortality, that's the easier and cleaner to measure. It really changes between countries, but what we had seen is also can be related to policies. It's a little bit, the absolute inequalities are lower, for example, in Northern European countries, where there is a lot of welfare and there are people actually, even the poor, they are actually accompanied. Then you have the relative inequalities in these countries that are higher. And so in general, if you improve population health, you reduce the absolute differences. You still have differences, but that's clearly a lower gradient in absolute terms. On the other hand, what really also changed a lot is the prevalence of smoking. Of course, and then the social patterning of the major risk factors is really another major contributor of the socioeconomic gradient. You see in countries where you have the lower socioeconomic position, people having, some places in the UK, 50% prevalence rate of smoking. Then you also have a huge gradient in mortality. And it's something that is maybe actionable politically, but
and there's probably some cohort effects too, right? Are changing, policies are changing, behavior.
Exactly. And then also this gradient in another thing is, as you say, it changes over time and not at the same time in different countries because of this transition of risk factors. Imagine also the socioeconomic gradient is smoking. As you know, the better off were smoking more first, then it switched first in men, then in women. And then you have, in certain European countries, you have women highly educated dying, maybe it's changed like recently, but they were dying of breast cancer more frequently than the lower educated ones because of the lag between your exposure and when you actually have the disease. And other risk factors, like breast cancer was it's something I use when I teach, because also other risk factors like breastfeeding, the use of contraceptive pill, first aid, when you first have children, there are societal factors. So, and the gradient changes, and then it changes it changes even over time.
Thank you. I got to listen to my boss. Thank